Hi students, welcome to this live YouTube session. I hope you are well prepared now, very few days left in exam. And I know that you will do very good in exam. You have studied hard, now it's time to perform. My best wishes, hope you achieve success. So for my subject anesthesia, I have selected 25 questions which I will discuss. Hello Veer. Hi students, welcome to this live YouTube session. I hope you are. Okay, sorry, okay. Hi, Amardeep. Hi, Devangan. Let us start with the first question. A 2 years old child had a cardiac arrest during inguinal herniorrhaphy under GA administration during Jackson-Reed system. The graph showed end-tidal PCO2 monitor from tip of the endotracheal tube during cardiopulmonary resuscitation. Minute ventilation is unchanged. Which of the following is most likely cause of the change beginning at the arrow point? So there is a arrow point and here the graph changed during CPR. So what is the reason for change in this graph? Can anyone answer? Decreased fresh gas flow, inadequate chest compression, increased dead space, restoration of cardiac output. So what does it seem? What is the cause of this change in graph during resuscitation? Okay. Can anyone say? Okay, B, inadequate chest compression. Devangan, B. Anyone differs in the answer? B, B, A. Okay. I'm a little surprised because I think I have covered this in my regular classes. I hope most of you have attended my regular class. So none of you have given me the right answer, but no, not a worry. I will just very quickly explain it. So this is a question related to the ETCO2 graph during cardiac arrest. Yes, Veer, D is the answer. Wonderful. So I'm getting now correct answer. But let us discuss few things about capnography during cardiac arrest. So capnography, okay, during cardiac arrest. So capnography. You know, this monitor has become a mandatory monitor in CPR, and we need to attach it to the patient if we have put an airway device. And it does three things. Number one, it tells us that the airway device is at the right place. Number two, it tells us that whether our chest compression is adequate or not, right? So adequacy of chest compression. So it tells us about adequacy of chest compression, right? One very important thing which CAPNO tells us. See, if your patient is in cardiac arrest, right? If patient is in cardiac arrest, the ETCO2 will be 0 because there will be no circulation. And when you start chest compression, the graph will start return. So when we do the chest compression from 0, the graph starts returning. And the target is that we have to keep the ETCO2 value above 20 mm of Hg. This means our chest compression is good one. If it is less than 10, this means our chest compression is not good one. So less than 10, chest compression is inadequate. It is not a good chest compression. So we have to keep such chest compression that ETCO2 is above 20 mm of Hg. Got my point? Okay. Now, one third very important thing which the ETCO2 graph tells us that when we are doing the CPR, the ETCO2 is coming, let's say 25, and suddenly it becomes more. At this point, it changes. It becomes 40 or it becomes 45. This means patient's own circulation has returned. Return of spontaneous circulation. So if patient's own circulation has returned, then only we will have a normal cardiac output for a normal ETCO2 value. So in the chat box, can anyone write and tell me what is the normal ETCO2 value? What is the normal range of ETCO2 value? Yeah. What is the normal range of ETCO2 value? Yes. So what is the normal range I'm asking? Can anyone write? Danish? Jaya, anyone, please write the normal value of EtCO2 for me. Okay, I'm waiting. Wonderful, Wasim. It is 35 to 45 mm of Hg. So this is 35 to 45 mm of Hg. So guys, this can only be there if we have a good cardiac output, normal cardiac output. And when you are doing chest compression, you can try for normal cardiac output, but we will not achieve a normal cardiac output. We will just achieve an adequate cardiac output. So our EtCO2 graph will be less than 35. Once it reaches 35, 40, it becomes more, more than 25, 30, it starts appearing normal. It means patient's own circulation has returned back. So if you see in the question, at this point, the EtCO2 graph from 20 became 40. This means restoration of cardiac output, or we can write return of spontaneous circulation. We write it ROSC is achieved. What is the full form of ROSC? Return of spontaneous circulation. You know, in CPR, they have asked every possible question. Only question which is not asked in CPR is capnography, use of capnography during CPR. So I expect if they ask a new question from CPR, it could be relationship of CPR and capnography. And only two possible question is there on relationship of CPR and capnography. Number one, that what value of EtCO2 tell us that chest compression is adequate. Answer is it should be above 20 mm of Hg. So EtCO2 above 20 mm of Hg should be the value for adequate chest compression. So this is the first question if a new question is asked. And the second new question which I gave, that if normal EtCO2 is achieved, 35, 45, it has come the value. What does it mean? It means patient's own cardiac output has returned. This means return of spontaneous circulation. So this is one possible new question which can be asked. Everyone has understood this? Two new question can be asked in CPR if a new question is formed. CPR is one topic which is so frequently asked. They have asked every possible question. If a new question is asked, two things can be asked. One, EtCO2 value for adequate chest compression. So what answer it should be? Above 20 mm of Hg. And during CPR, if EtCO2 value becomes normal, 35, 45, what does it mean? It means ROSC, return of spontaneous circulation. So two new questions I have discussed with you. You have understood, all of you? Okay. So I'll move to the next question. If you have a doubt, you can write in the live chat box. I will deal with the doubt as I see it. Next question. Now, this question, I don't know. I don't want to miss this question discussing with you anytime I am discussing anesthesia question, because this is one question which I saw so frequently being asked in exam. A 2-year-old male child posted for anatomy. In pre-anesthetic evaluation, his airway appears to be difficult. The anesthetist planned intubation without paralyzing the patient. All of the following inhalational agent can be used for induction and intubation in children except. Now, guys, I have little bit changed the question just to prove one point. And the point which I want to prove is, don't overread the question. This is my tip for today. A question may seem a similar kind of question which has been asked previously in exam. So many times previously in the exam question has been asked, best inhalational agent for induction and intubation, or best inhalational agent for induction. And the blind answer used to be sevoflurane. Here, little I have twisted the question. All of the following inhalational agent can be used for induction and intubation in children except. Now, if I change the question, if from here I change the question, I make it, which is the agent of choice for induction and intubation? What should be the answer? I have changed the question, guys. I'm asking that the same question, which is the agent of choice for induction and intubation. This is an old question. So many times it has been asked in exam. Yes, Asif, please tell me. I have changed the question. Agent of choice for induction and intubation. Inhalational anesthetic, agent of choice for induction and intubation. Yes, actually, answer should be SIVO, if it is the question. But this is not the question. The question is, all of the following inhalational can be used for induction and intubation in children except. So SIVO is best, undoubt. Desflurane, this is a respiratory irritant. Respiratory irritant. And anywhere, if intubation, induction is mentioned, this is contraindicated for induction. So we don't use desflurane for induction. We never use desflurane for induction. Halothane, again, has a good smell. So halothane can be used if sevoflurane is not in the option. Nitrous oxide, we can give along with the oxygen, nitrous oxide, and sevoflurane for induction. So it can also be used. So what cannot be used? The desflurane cannot be used. Got it? Yes, Wasim, because it is irritant. Desflurane is irritant. So we have solved 2-3 questions. A possible question which can be asked in exam, in your exam. If they ask induction and intubation agent of choice, among inhalational we are talking, the answer has to be sevoflurane. Sevoflurane, right? If they are asking which is contraindicated for induction, answer has to be desflurane. Desflurane is contraindicated for induction. If SIVO is not there in agent of choice for induction, the next agent after SIVO, halothane. So halothane is next agent of choice after SIVO. Why? Because it also has good smell. So it can also be used. Okay, Veer has asked, it is only in pediatric? No, guys. For any age group of patient, the answer would be same. Why the question is always formed with pediatric? Because this inhalational mode of induction is more commonly used in pediatric patient. For adult, generally we go for IV mode of induction. That's why when they form a question, pediatric patient is always in the mind, right? So they always ask the question along a pediatric patient, right? That is the reason, because pediatric, we go for inhalational induction. Adult, generally we go for IV induction. But the answer wouldn't change, even if the age of the patient is changed from 2 years to 20 years. Got my point? So everyone has understood? Veer, have you understood? The answer wouldn't change. It would be same. Okay? So this is our second question. Now coming on the next question. A 48-year-old ASA grade 1 female patient posted for a right mastectomy with radical lymph node resection. All of the following are required intraoperative monitoring except. So the patient is ASA grade 1. This is what we have to pick. And the surgery is right mastectomy, which is a low risk surgery. Even if it was a medium risk surgery and the patient is ASA grade 1, we don't need any special monitoring. What we do is basic monitoring. Okay. So we need to remember any such question asked on monitoring. We need to remember three important things in monitoring. Number one, that there are 5 basic monitors. In monitors, we have 5 basic monitors. Okay, very good. You all are answering. Okay. I'll come back. But guys, why some of you are answering incorrect? Some of you are giving me the right answer. At this level, I don't want any confusion. So we'll discuss first and then we'll come with the answer. Yeah, some of you are definitely giving me the right answer. Kaushal, Priya, Lily, Neha, all have given me the right answer. Okay. So basic monitors. There are 5 basic monitors. What are those? ECG, NIBP, pulse oximetry, capnography, and temperature monitoring. These we always attach in all patients. And apart from this, there are two desirable monitor. So there are two desirable monitor. Okay. So desirable monitor, what are? BIS monitoring, by spectral index, or BIS, or neuromuscular monitoring. Another one is neuromuscular monitoring. Okay. If we give our patient general anesthesia, right? General anesthesia, then we try to put these two desirable also, right? We try to put these two desirable also. And rest any other monitor, 5 plus 2, leaving these 7, rest any other monitor we attach according to the comorbidity of the patient and according to the type of surgery, right? So other monitor, what are the other monitors? So many, guys, so many. Like one in the option, CVP monitor, or pulmonary artery pressure monitoring, or transesophageal echocardiography, or invasive blood pressure monitoring. These are our other monitor. They are attached according to comorbidity and type of surgery, right? If I'm expecting a huge blood loss in surgery, then I would go for invasive blood pressure monitoring. If my patient has a cardiac disease, I would go for CPP monitoring. See our patient, right? Let us see our patient. The patient is ASA grade 1, having no comorbidity, and surgery is a right mastectomy, hardly a 20 ml, or if the surgeon is a very lousy one, 50 ml blood will be lost. Not more than that. Maybe a little more. It's still lousy surgeon. But these surgeries are not known for causing, let's say, a huge blood loss. So since they will not cause huge blood loss, or nothing special about this surgery, we would go for routine basic monitoring plus 2 desirable if we have it. So ECG is basic monitor. So I will attach it. Bispectral index is a desirable monitor. It's under GA, mastectomy, I would attach it. Capnography is a basic monitor. I have to attach it. And this central venous pressure monitoring, this comes under other monitor. This is not attached. Not attached. Why? This is invasive monitor. If it's not required, why we will attach it? So this is not attached. So answer is central venous pressure monitoring. Okay. And Wasim asked me, what is T, ma'am? T stands for transesophageal echocardiography, right, Wasim? It is transesophageal echocardiography, right? Transesophageal echocardiography. Now, guys, only 2 things you have to remember about this monitor, which can be asked sometime. Number 1, that this is the best perioperative cardiovascular monitor. So in case of any cardiovascular comorbidity, if I want to attach the monitor, I can attach this monitor. This is most sensitive perioperative cardiovascular monitor. So this is, guys, best cardiovascular monitor we attach in intraoperative. The next thing which can be asked, this is best, most sensitive to diagnose air embolism. This is most sensitive to diagnose air embolism. Got it? So this is the best monitor to diagnose air embolism. Got it? So remember this. Okay? Okay. So this is all about this third question. Any doubt? I hope, Wasim, I have solved your query on T, transesophageal echocardiography. Anyone, any doubt in any question, you can put in the chat box. As I see the question, I would come on the question. And I proceed further on my next question. An induction dose of ketamine was used in pediatric patient. What are the factors during anesthesia with ketamine which would have contributed? Now, what are factors during anesthesia ketamine which would have contributed in the patient? I mean, they are asking what is the clinical feature of, which is the true thing about ketamine? Okay, first option is analgesia. Second is attenuation of respiratory response to carbon dioxide, less compared with other IV anesthetic. Third, decreased cerebral metabolic rate, complete obtundation of laryngeal reflexes. So they're asking which is a true property of ketamine. Can anyone tell me? Can anyone pick the true property of ketamine for me? Okay, I'm waiting. So a lot of you have answered B, 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 all of you. Guys, okay. So I'll come back on the answer in a moment, okay? Let us discuss few things which I think you should know about ketamine, and then we'll come on the answer, okay? Okay. Ketamine, what are the 5 points of ketamine which can be asked in exam? First point, ketamine can cause dissociative anesthesia. Dissociative anesthesia. Okay, it can cause dissociative anesthesia. It's a special type of anesthesia which only ketamine can produce. Next, ketamine is a sympathomimetic agent. Yes, I got a right answer. Wonderful. So I got right answer for this question in the chat box. Okay, I'll come back on the answer, but let us see the 5 important points of ketamine. Dissociative anesthesia. Second, it is a sympathetic stimulant. Sympathomimetic. So it increases blood pressure, it increases heart rate, it increases intracranial pressure, it increases intraocular pressure, it increases all the pressure of the body. Why? Because it is sympathomimetic. So it would not decrease any pressure. First, it will cause hypertension, because tachycardia, because it is sympathomimetic. Then, ketamine is a very good analgesic. Now, guys, very good analgesic. Ketamine is a wonderful analgesic. No other IV anesthetic agent is good analgesic, right? It is a wonderful analgesic. Then, next important point about ketamine, very important point. Ketamine can be given by any route. I can give it IV, I can give it IM, I can give it oral. So it can be given by multiple routes, even rectal it can be given. And next, it causes emergence delirium. Emergence delirium. So if you remember these 5 important points, you will not miss a question of ketamine. Now, ketamine increases BP and heart rate. So in shock patient, it is agent of choice. So since it increases BP and heart rate, in shock, it is agent of choice. It increases ICP, so contraindicated in neurosurgery. It's a good analgesic. It is used for analgesia as well. It causes emergence delirium. This is a favorite question of exam. And it causes dissociative anesthesia. And it acts on NMDA receptor, unlike other agents which acts on GABA receptor. Now let us see the options. Analgesia, this is the right option. So I would keep it. Let's read the other options. Attenuation of respiratory response to carbon dioxide less compared to other IV agents. This is an old school of thought. That's why I have put it in the option. Now, previously it was thought that ketamine causes less respiratory depression compared to other agent. But if you use it for induction anesthesia, it is in the dose which is causing similar kind of respiratory depression. So I have not discussed any time in my lectures that it is causing less respiratory depression compared to other agents. So don't go for it. That's a older school of thought. Sometimes I saw this option, see this option in the old questions. So that's why, to just take away the confusion on this drug, I have kept this option. So analgesia would be the right answer. Decreases the cerebral metabolic rate. It increases cerebral metabolic rate, right? Complete obtundation of laryngeal reflexes. No, this is an incorrect statement. So answer is analgesia. Yes, Wasim, we can use ketamine for 3 important things. Number 1, shock, it is agent of choice. Bronchial, asthma, it is agent of choice. And it is used for analgesia in subanesthetic dose, right? It does not cause obtundation of laryngeal reflexes. It causes less obtundation of laryngeal reflexes. That is why In pediatric, we very commonly use it. Because it preserves the reflexes and there is a little less risk of aspiration compared to other agents. So guys, one clear-cut answer we have in the option. Don't get confused. Ketamin is a wonderful analgesic. No other IV anesthetic is analgesic. Yes, Wasim. Shock, it is agent of choice because it increases BP. And even in cyanotic heart disease, it is induction agent of choice because it increases blood pressure. In cyanotic heart disease, we don't want reversal of shunt to happen. In bronchial asthma, it is agent of choice. And for analgesia, it's a good agent. So keep it in mind. And very important, according to me, if they will think asking a question on ketamine, they will ask about emergence delirium, a very known side effect of ketamine. It can cause emergence delirium. Okay? Next question. Okay. All of the following statements are incorrect about treatment of prolonged Suxamethonium apnea due to plasma cholinesterase deficiency, except. So all are incorrect means which is correct treatment. So simple. What is treatment of Suxamethonium apnea? So what is treatment of Suxamethonium apnea? This is the question in one line. So I'm waiting for the answer. Put the answer in the chat box. Yes, guys, put the answer in the chat box. You tell me. Okay, A, plasmapheresis, reversal with incremental dose of neostigmine, continue anesthesia and mechanical ventilation till recovery. All of the following are incorrect. So which is correct, guys? Which is correct? Correct treatment of Suxamethonium apnea. So none of you are giving me the right answer. I'm waiting. Yes, Lily, you are correct. That's the right answer. So guys, we are discussing about Suxamethonium apnea. We need to, yes, Vishal, you are also right. So let us talk about Suxamethonium apnea. Suxamethonium apnea. You should be very, very crystal clear with this word. Suxamethonium apnea means prolonged apnea after normal dose of succinylcholine, right? So this is prolonged apnea after normal dose of succinylcholine. Okay. Prolonged apnea after normal dose of succinylcholine. So why this happens? Because the enzyme which metabolizes succinylcholine is absent or not normal. So it can happen due to presence of atypical pseudocholinesterase, or due to pseudocholinesterase deficiency. So this is the enzyme which metabolizes succinylcholine. If it is not there, or if it is faulty, we would get a prolonged apnea after normal dose of succinylcholine, right? And how do we manage it? So what are the options? Options are transfusion of fresh frozen plasma. Okay, so you mean if we will give fresh frozen plasma, the pseudocholinesterase deficiency or atypical pseudocholinesterase would go away. Okay. Plasmapheresis, that is, we will take away the succinylcholine from blood. Okay. Incremental dose of neostigmine. I mean, succinylcholine cannot be reversed by neostigmine. What's the use of neostigmine in this case? Guys, what happens? This is your neuromuscular junction. You have given IV succinylcholine and the succinylcholine has escaped metabolism and it huge amount has reached neuromuscular junction. And the neuromuscular junction is under the prolonged effect of succinylcholine. Patient cannot breathe. Patient will die. So what we need to do is to ventilate from outside. So we need to do positive pressure ventilation. If you will try to give fresh frozen plasma or do a plasmapheresis, you are targeting plasma. But the drug is now no longer in plasma. It has escaped plasma and reached neuromuscular junction. So as long as drug is having its effect, we need to ventilate. So the primary treatment of Suxamethonium apnea is positive pressure ventilation. That is, we continue. Number of times in OT this happens. I gave succinylcholine. I expect in 8 minutes paralysis will go away. But what is happening? Prolonged apnea. Now I don't get too worried because there's a possibility of Suxamethonium apnea. What do? I put the patient on ventilator. Wait for the recovery to happen. So answer is D. Keep it in mind, right? And thank you, Rax. Okay. So fifth question we have solved. Next. Very important question, guys. I expect one question on mechanical ventilation. So tips and tricks for solving the questions on mechanical ventilation. So everyone, let us read the question first and then little twist I will do in this sixth question. And we will make it multiple question so that we cover the mechanical ventilation question. You know, other question I have covered in so many videos and so many discussions and everything. This is one topic I kept specially for the YouTube series so that I discuss with you just before exam and keep it fresh in your mind. Okay. The question is, an acute pancreatitis patient weighing 70 kg came to emergency, was shifted to the ICU and given an intubation and was intubated. His ventilatory settings are FiO2 90%, right? PEEP 12, respiratory rate 16, and tidal volume 420. The result of the ABG analysis is given below. Which of the following would be next step in the management? So ABG 7.33 was the pH, 110 was the PaO2, PaCO2 was 58, and SpO2 was 100%. So what would be the next change which we will do in management of this ventilatory setting? So I'm getting the answers. Okay, you give me the answer. I would not tell the answer. I would just discuss about mechanical ventilation. Okay, everyone, please pay attention. On the screen, you can put your answer in the chat box. Just pay attention. Okay, guys. Mechanical ventilation. Why do you put a patient on mechanical ventilation? For two reasons. If the patient has inadequate oxygenation or if the patient has inadequate ventilation. So you put it if the patient has inadequate oxygenation or if the patient has inadequate ventilation. Okay. So this is the two reasons why we put a patient on mechanical ventilation, right? Inadequate oxygenation means, what does inadequate oxygenation means? PaO2 less than 60 mm of Hg. If PaO2 is less than 60 mm of Hg, this means inadequate oxygenation. Inadequate ventilation, what does it mean? If PaCO2 is above 45 mm of Hg or pH is below 7.35, right? Normal pH is between 7.35 to 7.45. It is below 7.35 or PaCO2 is above 45. This means inadequate ventilation. So how we will get this report? By ABG. ABG, after putting a patient on ventilator, we always wait for 20 minutes after the setting and then do a ABG. Now, you have seen ABG. ABG has the pH, PaO2, PaCO2. These are the parameters present in the ABG. We are just concerned with these three parameters. We'll only focus on these three. If patient has PaO2 less than 60, oxygenation is problem. If patient has pH and PaCO2, pH is less than 7.35 and PaCO2 more than 45 mm of Hg, ventilation is inadequate. Okay. Okay. Now, guys, what change we will do in this? If oxygenation is a problem, then two things we can do. We can increase the FiO2 of the patient, or we can increase the PEEP of the patient, right? The PEEP setting. What is FiO2? How much oxygen concentration you are giving to the patient. You are giving your patient 80%, 60%, 70% oxygen concentration. As you increase it, as you increase the FiO2, the PaO2 would increase, right? And as you increase the PEEP is positive end expiratory pressure. As you increase the PEEP, the positive pressure in the alveoli is higher, alveoli remains expanded, and O2-CO2 exchange happens from a wider surface area. Again, oxygenation improves. So PEEP is the another way to improve the oxygenation. Now, guys, what we do, we titrate at what minimum PEEP and minimum FiO2, there would be just adequate oxygenation. I would just make a small chart. If the PEEP and FiO2, how do we balance it? If the PEEP I have kept is 5 mm of Hg, the FiO2 should be 0.4, the balancing FiO2. I mean, this should be. If the PEEP I have increased 6, the FiO2 parallelly, which I would have increased to achieve the oxygenation is, let's say, 0.5. If PEEP is 7, 0.5 to 0.6. If PEEP is 8, 0.6 to 0.7 FiO2. If PEEP is 9, 0.7 to 0.8 FiO2. So what we do, we increase PEEP and we increase FiO2 in combination to achieve right PaO2 concentration. So if I have patient with PaO2 less than 60, let's say patient has 52 mm of Hg PaO2 and the PEEP is 9, but the FiO2 is 0.6. So what I will increase? I will increase FiO2. Got my point? PEEP was 9, right? So PEEP was on the higher side. So what I will increase? I will increase FiO2. I will increase the FiO2 from, let's say, 0.5. If it is 0.5, I will make it 0.7. If my FiO2 is 0.9 and PEEP is 7 or 8, I will increase my PEEP. Let's say I will make it 10. So I will balance at what minimum FiO2 and minimum PEEP, just adequate oxygenation. I increase in combination. PEEP and FiO2s are increased in combination. If this is the PEEP, this should be the FiO2, right? It should be parallelly increased. So this is for oxygenation. If the ventilation of the patient is suffering, then we increase the tidal volume and the respiratory rate, right? If the ventilation is suffering, we increase the tidal volume and we can increase the respiratory rate because we have to increase the minute ventilation of the patient, right? Normally, we put a patient on ventilator, we keep it low tidal volume, we keep it 6 to 8 ml per kg body weight and respiratory rate near the normal respiratory rate, let's say 12 to 17 breath per minute, okay? Now, what happens? Patient has 30 breath per minute of the respiratory rate, right? The respiratory rate is very high and tidal volume is, let's say, 6 ml per kg body weight and PaO2 is 50. So how can I bring the PaO2 down? Already the respiratory rate is very high. So I will increase the tidal volume. If the respiratory rate is not high, tidal volume is high, I will increase the respiratory rate. So we balance at respiratory rate and tidal volume what adequate PaCO2 we will achieve. So what I'm trying to tell, normally we start with 6 to 8 ml per kg body weight of the tidal volume. And we start with 12 to 14 breath per minute. If the PaCO2 is less than 40, right? 45 is normal, more than 50. 45 is normal. If it is increasing and if it becomes more than 50, little bit permissive is allowed. If it becomes more than 50, I start increasing the respiratory rate. I go on increasing the respiratory rate. If it becomes between 25 to 30 breath per minute, I will not further increase the respiratory rate. What I will increase? I will increase the tidal volume. Okay. So this is how we balance. Till 30, I can increase the respiratory rate. Now, if patient is not improving, I will increase the tidal volume. Beyond 30, I will not increase the respiratory rate because expiratory time will decrease and there would be more risk of CO2 retention in the patient. So till 30 breath per minute is the maximum limit for increasing respiratory rate to increase the minute ventilation, right? Beyond that, we don't increase it. So What we increase beyond that? Tidal volume. So let us see the question. So patient, what is the problem? PaCO2 is higher. PaCO2 is higher. His tidal volume is 420. He is 70 kg. So it is 6 ml per kg body weight. Okay, that's adequate. His respiratory rate is 16 breath per minute, 16 per minute. And his PaCO2 is 58 mm of Hg. So guys, what should I increase in this? We should increase the respiratory rate. But what are in the options? Increase the PEEP to 16. Well, oxygenation is not a problem. Why should I touch the PEEP? No need to touch the PEEP. Increase the tidal volume. Okay, I can increase the tidal volume of the patient. Reduce the respiratory rate. Well, if I reduce the respiratory rate further, the PaCO2 will increase. So I have to increase the tidal volume. Got it? Okay. I hope everyone has got the right answer. Yes, wonderful. Okay, I change the question. I now make the question PaCO2 48 mm of Hg. Okay. PaCO2 48 mm of Hg. Near normal. Right? What would be the thing you will now alter? Same options. Same options. So now I want the answer. I have changed the question. PaO2, I have clear CO2, I have made normal within, I'm near normal. So what you will do now? What you will do now? Yes, anyone? So I'm waiting. I plan to give my maximum time to this question. Okay. Oh, it's confusing, Yen. Again, I can explain. I'll try to make it less confusion. Okay. Again, answer A. So now I have made PaCO2 normal. And I'm asking now what changes you will do. Okay. What are you writing, Vasant? I'm not able to increase the thickness of pencil. Okay. Okay, guys, I'll do that. Okay, now every parameter is normal in my next question. So what I will do? FiO2, what FiO2 we are giving to the patient? 90%. Now this 90% FiO2 is very toxic FiO2, very high FiO2. I will try to reduce the FiO2. So if everything is normal, we try to reduce the FiO2. Okay, then the answer would be reduce FiO2 if the ABG would have been normal. But in my question, the ABG was abnormal, PaCO2 was higher side. So I first try to correct the PaCO2 by increasing the tidal volume. Okay, okay, everyone. Again, everyone again. I'm rubbing it and again I will discuss this. So please, everyone, pay attention on the screen for a second. Okay. When a patient comes, and if I have to put the patient on mechanical ventilation, so what do? I fix the tidal volume. Let's say normally we put the tidal volume 6 to 8 ml per kg body weight. Okay. Then respiratory rate, normally between 12 to 17 breath per minute. Okay. IE ratio, inspiratory, expiratory time. Normal IE ratio, our expiratory time is more, inspiratory is less. So what we try to replicate the same in the patient. 1:2. Then FiO2. FiO2, how much I keep? FiO2, we try to keep, when the patient comes, 1. Initial, first FiO2. When we try to reduce it, FiO2, 1 we keep, that is we give the 100% oxygen, and then we try to reduce it to non-toxic level, to how much? We try to reduce it to less than 0.6. We try to keep it less than 0.6. Okay. So initially we keep it 100%, then we try to reduce it. And PEEP generally we keep when the starting PEEP 5 mm of Hg. So this is the first setting, initial setting. And any change we do after 20 minutes of setting, after seeing the ABG. So when we see the ABG, then only we can change the parameter. When I saw the ABG, I have to see two things. I have to see the PaO2, which tell us about what? It tells us about the oxygenation of the patient. It should be above 60 mm of Hg. And we see PaCO2 and pH. These two tell us about the ventilation of the patient. If the PaCO2 is above 60 mm of Hg, on this setting, everything fine. I try to reduce the FiO2 from 100 to less toxic level of FiO2, right? I go on decreasing it because we don't need 100% oxygen if we are achieving the PaO2. If PaCO2 and pH is altered, if PaCO2 is more than 45, pH is less than 7.35, that is respiratory acidosis. Then we try to increase the tidal volume respiratory rate for increasing the minute ventilation. I told you, first we increase the respiratory rate till 30 breath per minute, right? If we don't increase the respiratory rate further than 30 breath per minute, then we start increasing the tidal volume of the patient. Okay. If patient is receiving 6 to 8 ml of tidal volume, we increase the respiratory rate till 30 breath per minute to achieve the adequate ventilation. If patient is not able to achieve the adequate ventilation on 30 also, then we start increasing the tidal volume. This is for ventilation. If PaO2 is less than 60, then we increase either FiO2 or PEEP. So this was, I told you about a small chart which we balance. We try to balance. So if PEEP is 5, right? And patient is not achieving the adequate oxygenation, right? I would increase the PEEP because already the FiO2 is 1. I will make the PEEP, let's say, 8 mm of Hg. Still, the patient is not achieving the FiO2 oxygenation. This is the maximum FiO2. I would further increase the PEEP to 10 mm of Hg. So I would go on increasing the PEEP for balancing my oxygenation because FiO2 is already very high, right? So keep this in mind. Any doubt? I think I try to explain you. Yen, have you understood Yen now? It's not confusing. It's mathematics. If oxygenation is a problem, increase FiO2 or PEEP. If ventilation is a problem, increase respiratory rate or tidal volume. When you are increasing FiO2 or PEEP, you see which is more, which is less. If FiO2 is already high, go on increasing PEEP, right? So try to balance. And for ventilation, again, mathematics. Fix the tidal volume 6 to 8 ml per kg body weight, respiratory rate 17, 18. Not achieving the ventilation, go on increasing the respiratory rate up till 30. Not achieve, then increase the tidal. The simple maths. Okay, cool, Yan. So you have understood. So this is an important question. I'm expecting one question. And you know what I'm expecting? I'm expecting they will ask a normal question. They will give a patient is on ventilator and they will give the ABG a normal parameter and they will ask you what you have to change. Look for FiO2. FiO2 would be on the higher side. Start decreasing the FiO2. This is something which I see the residents forget in the ICU. And the examiners are making a lot of question on this, mind you. So keep it in mind. We have to decrease FiO2. If we have achieved our oxygenation, we cannot go on keeping 100% or giving 100% oxygen. It's a toxic oxygen. Toxic oxygen. Got it? Okay, now next question. Again, a very important question I'm expecting to be asked in exam. Irrespective of patient's breathing effect, not breathing effect, breathing pattern. Which of the following airway device helps to maintain FiO2 between 0.2 to 0.6? Okay, I want an answer. 2 point you have to, only one thing you have to take care in this question. Irrespective of the patient's breathing pattern, this is the only line which we need to pick. So answer, I want answer. Yes, guys. What's the answer? In the chat box? C. Oh, wonderful. All are giving me right answer. Wonderful. So thankfully, the favorite topic Oxygen therapy is crystal clear to all of you. Wonderful. Yeah, guys, we know that oxygen delivery device. Now, Raj has given me the answer A. That's a wrong answer, but I want to just pick that wrong answer. Raj, you don't have to look here 0.25 to 0.6. What you have to look is irrespective of the patient's breathing pattern. Now, oxygen delivering device are of two types. Number one is low flow variable FiO2 delivering device. And the second is high flow fixed FiO2 delivering device. Fixed FiO2 delivering device. Okay. Low flow variable FiO2 delivering device. Low flow means the device will deliver less than equal to 15 liter per minute. This is the maximum flow which these devices can give. And variable FiO2 means FiO2 which it will give will vary from patient to patient. It may be 0.4 in you, it may become 0.2 in me. It depends upon the breathing pattern of the patient. So that is why we achieve something called variable FiO2. The FiO2 will vary. So these devices are not independent of patient's breathing pattern. They are dependent on patient's breathing pattern. And three devices comes under it. Nasal cannula, face mask, and non-rebreathing mask. These three devices are the devices which comes under low flow variable FiO2 delivering device. High flow fixed FiO2 delivering device. High flow fixed FiO2 delivering device. They deliver the flow up to 60, more than equal to 60 liter per minute. And FiO2, what we give is fixed. They give fixed FiO2. They are independent of patient's breathing pattern. Independent of patient's breathing pattern, right? Independent of patient's breathing pattern. So what are the devices which comes under it? Venturi mask, high flow nasal cannula, HFNs. These two devices, remember. So Vaseem has written Venturi gives 100% oxygen. No, Vaseem. Venturi mask can never give 100% oxygen. Maximum FiO2 which Venturi mask can give is 60%. But it will give fixed FiO2. It does not depend on the breathing pattern of the patient. So though Venturi cannot give more than 60% of oxygen concentration, the benefit of Venturi is whatever oxygen concentration we want, it will give. It has a fixed FiO2, right? Okay. HFNC, high flow nasal cannula. This can give up to 100% oxygen. Okay. High flow nasal cannula. Conventional nasal cannula is your low flow device. High flow nasal cannula is a special nasal cannula, which is based on the blending system. There is a blender which mix oxygen and air. Then there is a humidifier which is attached to it. There's an inspiratory tubing and it is connected to the nasal cannula. This is high flow nasal cannula. Normal nasal cannula, just two cannula in both layers connected to the flow meter of the oxygen, nothing else. Oxygen flow meter. So it doesn't have a blender, no blender in normal conventional nasal cannula. This high flow nasal cannula is based on blending system. Got my point? Blender, it is a blender. So keep it in mind. Here, irrespective of the patient's breathing pattern, what will be the answer? Nasal cannula depends on the breathing pattern. Simple face mask depends on the breathing pattern. Venturi mask, independent of the patient's breathing pattern. Answer is Venturi mask. Got it? Okay. Here, you don't have to bother about the FiO2. You have to see, irrespective of the patient's breathing pattern, which device it is. Okay? So answer is Venturi mask. Got it? Okay. Okay, guys. Next question. 8th question. Which of the following intervention is not a part of advanced cardiovascular life support ACLS protocol in cardiac arrest patient aged 60 years? Yeah. What's the answer? So what is not part of ACLS? What is not part of ACLS? Yes, guys. What is not a part of ACLS? Okay. Amiodarone, defibrillation, adrenaline, soda bicarb. So what is not done in? Okay. Okay. Akhil has given me A answer. Yen has given me D answer. Laiba, D. Wonderful. Most of you are giving me the right answer. So many times I have discussed with you ACLS, and I have never mentioned sodium bicarbonate. So this is not a part of ACLS, not a part of ACLS. Okay, everyone. So I would just very quickly discuss advanced cardiac life support. Advanced cardiac life support. This means doctor is giving the life support. So when I am the doctor, I would see the rhythm of the patient and then manage the cardiac arrest. So cardiac arrest has two rhythm, two type of rhythm. 4 rhythm is possible, 2 type. Shockable and non-shockable. Non-shockable. Shockable and non-shockable. Okay. Shockable. 2 type of rhythm in this. Ventricular fibrillation and ventricular tachycardia. Non-shockable, asystole or pulseless electrical activity, PEA, pulseless electrical activity. So what are the interventions we do in shockable and non-shockable? In shockable, 3 important interventions apart from CPR. So in all cardiac arrest, we do CPR, that is compression and ventilation. And apart from compression and ventilation, what other intervention we do? In shockable, other intervention what we do is we give the shock, that is defibrillation, and 2 emergency drugs I can give, adrenaline, amiodarone. Adrenaline and amiodarone. If amiodarone is not present, I can give lidocaine. Non-shockable, what we do? CPR and only one more intervention, adrenaline, nothing else. Adrenaline and nothing else. Okay, everyone? So, everyone, these are the intervention what we do, right? These are the intervention what we do. So, is there any soda bicarb mentioned in ACLS intervention? No, nothing. So, anything apart from adrenaline, amiodarone, defibrillation, nothing. I mean, lidocaine can be, if there is amiodarone is not there, we use lidocaine. So, lidocaine can be the answer. But sodium bicarb or anything else would not be the answer. These are not the intervention what we do. So, answer is sodium bicarb. Any doubts? Simple question. I just picked up from your previous year question. Okay. Okay. This is a question which is asked in NEET. Previous year question. The image given below showed neuromuscular monitoring of a patient after anesthesia or during anesthesia. After or during anesthesia. Okay, everyone. So what is the most common nerve which is used for monitoring? What is the most common nerve which is used for monitoring? So simple question. I mean, I will try to manipulate this question in few ways. Okay. Number 1, most common nerve monitored during anesthesia. So most common nerve monitored during anesthesia. Okay, next question. Most common nerve. Very good. Most of you are telling me the right answer. Most common nerve for neuromuscular monitoring. All are the same question. Why do we monitor a nerve during anesthesia? We monitor a nerve during anesthesia to see the action of neuromuscular junction. The most common nerve is ulnar nerve. Wonderful. What are the questions they have asked? This is a question, this is a question, this image is a question. For all these 3, what was the answer? Ulnar nerve. Okay. Now, what new they can form? What new they can ask? on this? I think they can form only one new question. And that new question is, why ulnar nerve? Why ulnar nerve? Two reasons why ulnar nerve. The reason one, so why ulnar nerve is best for monitoring. So why ulnar nerve is best for monitoring? Number one, ulnar nerve is best for monitoring. Number one, because it is easily accessible. Easily accessible. And number two, it correlates with the paralysis of the respiratory muscle in the best way. So correlates in best way with paralysis of respiratory muscle, with paralysis of respiratory muscle. So it will tell us best when the respiratory muscle is in paralysis or is out of paralysis. So this is the best nerve which we monitor during anesthesia. Yes, and one another question, which is the most common stimulus used for neuromuscular monitoring. So for neuromuscular monitoring, the most common stimulus is used is your train of four stimulus, right? We see either the top count or we see the top ratio, and we know whether the patient is in paralysis or not. Is in paralysis or is out of paralysis. Got it? So, top stimulus. So, this was our 9th question. Coming on 10th question. Again, an expected question. Arrange the following anesthetic on the basis of its potency. So how do we arrange the anesthetic agent on the basis of potency? How do we arrange the anesthetic agent on the basis of potency? MAC, by understanding their MAC. Okay. So MAC is inversely proportional to potency. It is inversely proportional to potency. High MAC, low potency. Low potency. Low MAC, high potency. High MAC, low potency. Low MAC, high potency. So we have to arrange them on the basis of their potency. Matlab, from low to high MAC. So on the basis of potency, low to high MAC. Low to high MAC means high to low potency. Right? So which agent has lowest MAC? Methoxyflurane. Methoxyflurane. So methoxyflurane has lowest MAC. So methoxy is most potent. Methoxy is most potent. After that, the sequence which I talked about. Halothane, isoflurane, sevoflurane, desflurane. The potency varies in this. MAC is increasing, potency is decreasing. Then nitrous oxide. Nitrous oxide is least potent. It has a MAC of 104. So it is least potent. So how do we arrange? Methoxy, halothane, isoflurane, nitrous oxide. This is the right answer. Ajay has given me the right answer. Right? So A is the right answer. Methoxy is most potent, then halothane, then isoflurane, then nitrous oxide. Guys, methoxy is not in clinical use. But two things you have to remember about methoxy. It is most potent and it is most nephrotoxic. So methoxyflurane is not in clinical use. But 2 points which you have to remember. It is most potent and it is most nephrotoxic. So remember, in potency, it is high. It has a highest potency and it is most nephrotoxic. That's why not in clinical use. So it is not in clinical use. Remember, it is not in clinical use. Okay. But it is most potent. Next question. Identify the incorrect statement in RSI. So it is RSI, question based on RSI, rapid sequence intubation. Pre-oxygenation with 100% oxygen is done High volume, low pressure cuff is used. It is method of choice in cardiac arrest patient. Induction agent and muscle relaxants are given simultaneously, which is incorrect statement. So can anyone tell me the answer? So I will wait for the answer. So can you tell me the answer? Again, I expected question. Which is false about rapid sequence intubation. So you'll tell me the answer. I would discuss the RSI meanwhile. So RSI, that is rapid sequence induction intubation. Induction and intubation. Now, why is this RSI done? This is done in emergency patients, emergency surgeries, emergency surgery. What is the reason for doing this? To prevent aspiration. To prevent aspiration, right? We do it to prevent aspiration. What are the steps? 5 steps you have to remember. Number 1, 5 steps of RSI. Pre-oxygenation is mandatory. Pre-oxygenation is mandatory. So pre-oxygenation is mandatory. We give 100% oxygen. Number 2, cricoid pressure is applied. Cricoid pressure or Selix maneuver. Selix maneuver, right? We apply the cricoid pressure or Selix maneuver. We press the cricoid cartilage to press the trachea, and trachea presses the esophagus. So full stomach patient, if we press the trachea presses esophagus, the food of stomach will not come in oral cavity and the patient will not aspirate. Then we give IV thiopentone for induction and IV succinylcholine for paralysis. Why succinylcholine? Because it is fastest acting. And 4, positive pressure ventilation is contraindicated. Positive pressure ventilation is contraindicated. 5th, we do a laryngoscopy plus intubation. We do a laryngoscopy and intubation. These are the 5 steps of RSI. RSI is done in emergency procedure to prevent aspiration when the patient is full stomach and we don't have adequate time to keep the patient NPO prior to surgery, to prevent aspiration. Or we do it in those patients, even during elective surgery, who are at a high risk of aspiration. Now, let us see the options. Pre-oxygenation with 100% oxygen for 3 minutes. This is right. Okay, guys. Sorry, you know, a lot of rain. It's raining very badly here at my place. So electricity gone. Okay. So first is correct. Pre-oxygenation with 100%, pre-oxygen with 100% oxygen for 3 minutes is done. Okay. High volume, low pressure cuff is used for intubation. This is normal. High volume, low pressure cuff is used. This is normal. So we use it. Yes, this is also correct. This is normal. It is method of choice in cardiac arrest patient. No, in cardiac arrest patient, we don't practice RSI. So this is incorrect, right? In cardiac arrest patient, we simply intubate the patient. So yes, Salman, your answer was correct. Or Atharva, Lily, Ishan, Jaya, all of your answers were correct. Answer is, it is incorrect statement. It is method of choice in cardiac respiration. Induction agent and muscle relaxant are given simultaneously. This is also correct option. Okay. So what is the answer? Which is incorrect statement, which is incorrect statement for rapid sequence intubation. It is method of choice in cardiac respiration. No, this is incorrect statement. Okay. So we have to remember this 5 steps of uh, RSI. Okay. Next question. Which of the following inhalational agent requires a special vaporizer? Guys, again, a favorite question of exam. Which agent requires special vaporizer? Which agent needs special vaporizing uh, special vaporizing principle. Okay. So which agent needs special vaporizing principle? Which needs a special vaporizer? Always answer is desflurane. Answer is desflurane. So desflurane needs special vaporizer. Desflurane needs special vaporizer. Got it? Okay. Why does desflurane needs a special vaporizer? Okay, I don't know which question you people are answering, because I don't expect any incorrect thing in this question. I don't know, Lily, Mukesh, Raj, are you answering 12th number question? I hope it is not. Yeah, answer is A. Answer is desflurane. Desflurane. Yes, actually, desflurane. Desflurane has 2 unique property. Number 1, it has boiling point at atmospheric pressure. So boiling point is at room temperature. Room temperature. So it boils at 23 degrees Celsius. And its vapor pressure is also very high. It has a high vapor pressure. So vapor pressure is high, boiling point is low. So because of this, it needs a special vaporizer. Special vaporizer. So everyone, desflurane is a royalty. It needs a special vaporizer. And remember, guys, the color code of desflurane is the color code of royalty, blue color. So desflurane, blue color code. The color code of royalty, desflurane. So there's one more question which can be asked about desflurane. Okay, everyone. Halothane, isoflurane, sevoflurane, desflurane. Okay, boiling point, these 3 same. Desflurane, 23 degrees Celsius, room temperature. Vapor pressure, these 3 same. This 770, high vapor pressure. Because of these 2, needs special vaporizer. Special hai, royalty hai. These are commoners. So guys, royalty has blue color. Blue is the color of royalty. CO is loved by children because it has a beautiful smell. So it has a yellow color. Yellow color, I mean bright color. Children like bright color. So yellow color is CO color. And halothane is most unstable. So it's a danger. Halothane is worst. It's a danger. And red is the danger color. And isoflurane, purple. The color left is purple. Iso, right? So try to remember. Children like SIVO. It has a good smell. So yellow color. Okay. Des is royalty, blue color. Halothane is danger, red color. And purple is for isoflurane. Yes, wonderful. You all are giving me right points about these drugs and the questions which can be asked about these agents. Yep. 14th. A 36-year-old woman is receiving general anesthesia for a diagnostic laparoscopy in Trendelenburg position with carbon dioxide insufflation. Right? During 15 minutes period after induction, her SpO2 decreased from 99 to 90%. EtCO2 increases from 30, I mean decreases, not increases, decreases from 38 to 18. FiO2 is 0.3. All the ventilator setting has been constant. Which of the following is most likely cause of decrease in SpO2? Okay, guys, very important, right? This patient is undergoing a surgery. After the surgery starts, suddenly the saturation drops and EtCO2 also drop. So fall in EtCO2, fall in EtCO2. This is a clue. Whenever we see this, fall in EtCO2, only one thing will come in our mind, embolus, embolus. Emboli can be anything. It can be air embolus, it can be carbon dioxide embolus, it can be fat embolus, it can be thrombus which has embolized. All will present in a same way, fall in EtCO2. Here, it is diagnostic laparoscopy. So surgeon was putting the port and he was using carbon dioxide to insufflate the abdomen to create a pneumoperitoneum. And what happened? That port went into one of the vessels and this caused CO2 insufflation in the blood and this resulted in carbon dioxide embolus. Okay, so answer is carbon dioxide embolus. Got it? So answer is whenever you see fall in EtCO2. Whenever you see fall in EtCO2, what will be your answer? Embolus. In this case, it is carbon dioxide embolus. How does the emboli presents when embolus happens? There is fall in EtCO2, fall in saturation, drop in blood pressure. All things will drop. Everything will drop. In embolus, everything will drop. Okay? So keep it in mind. Okay, next question. A nearly 70 years old adult was lying on the middle of the road with no response on verbal and tactile stimulus. Patient was pulled and emergency was activated. Pulse and breathing was assessed. Both pulse and breathing were present. What is done while waiting for the emergency to arrive? So very simple question. Patient was in middle of road with no response on verbal and tactile stimulation. So patient was unresponsive. When a patient is unresponsive, what do we do? When a patient is unresponsive, what we do? We do a scene safety. We first see the scene should be safe. So it was middle of the road. So patient was call for help. After that, call for help. After call for help, we assess pulse and breathing. Pulse and breathing. So pulse and breathing is assessed. If both are present, both pulse and breathing present. So patient is not in cardiac arrest. What do? We put the patient in recovery position. So this question is on recovery position. Recovery position. So both pulse and breathing was assessed. So they are going in the sequence. Patient was pulled to the side. Emergency was activated. Pulse and breathing was assessed. Both pulse and breathing were present. What we will do? So what we will do? We will put the patient in recovery position to prevent any aspiration to happen. So answer is patient is put in recovery position. Okay. Now head tilt and chin lift. When we will do? We will do this if patient, we have to give rescue breath. Rescue breath. That is when patient is in respiratory arrest. When patient is not breathing, only pulse is present. Right? So all these are done when we have to give rescue breath. Both are present, we have to put the patient in recovery position. Okay, so remember this chart. Next question. A trauma victim was brought to emergency. Patient was unconscious with blood pressure 70/50. Pulse rate very high. Which of the following is most preferred cannula to be attached to this patient? So most preferred cannula to be attached to the patient, right? So patient is a trauma victim and the patient is in shock. We have to do a resuscitation. Resuscitation. And for resuscitation, we will use thickest cannula available. Thickest cannula available. So what is the thickest cannula available? 14 gauge, which is orange. After that, 16 gauge, which is gray. Then 18 gauge, which is green. And then 20 gauge, which is pink. Okay, what are the options? 20 gauge. 20 gauge, routine cannula. 18 gauge, green cannula. 16 gauge, gray cannula. I would go for 14 gauge. 14 gauge, the orange cannula, which is very commonly used in trauma for fluid resuscitation. Fluid resuscitation. So whenever a question is on trauma patient and you have to give fluid, quick fluid, use the thickest cannula available. So 14 gauge is the thickest one. It is in the option. I would go for that as an answer. If it was not in the option, I would have gone for 16 gauge as an answer. Got it? So we will go for 14 gauge cannula. Any doubt? Okay. So remember, in shock patient, we give 14 gauge. We use 14 gauge cannula. Okay. So remember this. Okay. Okay. Guys, 2 cannulas. Just very quick revision of cannulas. So I said 16. Okay, I'll start with 14. 14, 16, 18, 20, 22, 24, 26. These are the available ones. These two, first two, these are used in trauma and cardiac surgery. Why? We have to give more fluid in these conditions. Fluid is given very fast. 14 gauge in kind of 2 minutes, I can give 500 ml saline. So 250 to 60 ml per minute. And 16 gauge in 2.5 minutes, I can give 500 ml bottle saline or RL. 18 and 20 gauge is our routine size. Routine size used in adults. In wards. Wards. Okay. So in wards, we use the 18 gauge cannula, right? 18 or 20 gauge. Okay. Okay. So in adults, these two cannulas, you need to remember their flow rate. 18 gauge, flow rate 90 to 110 ml per minute is the flow rate. 20 gauge, it is 55 to 60 ml per minute. We can give the fluid. Okay. These two cannula only, you have to remember the flow rate. So this is very important. Remember the flow rate of these two cannula. Now 22 gauge and 24 gauge. This is used in pediatric. And 26 gauge is used in old, elderly, or premature infant. Okay. So these are the indications. Okay. Next. Very important question. A 48-year-old woman with palpitation, when ECG was done, it showed the following rhythm. Her blood pressure and hemodynamics were deteriorating. What is the first line of management? Okay, guys. Who will tell me the answer? Yes. So patient is having palpitation. ECG was done. This is the ECG, what we see. And what is the management? That's the question. Yep. What is the answer? What is the answer? Okay. Hariom said A. Deepan said C. Raj C. Bharat A. Okay, Deepan, Bharat, what is the rhythm you are seeing in the monitor? Answer is, yeah. What is the rhythm you are seeing in the monitor? Why are you saying vagal maneuver? Are you thinking this is PSVT? No, guys, this is not PSVT. This is atrial fibrillation. These are the fibrillating waves of P wave has been replaced by fibrillating waves. And you can see the RR interval is not fixed. So pulse is irregular, and RR interval is not fixed. And the P wave has been replaced by fibrillating wave. This is atrial fibrillation. And guys, atrial fibrillation, which is a narrow QRS complex tachyarrhythmia. It comes under narrow QRS complex tachyarrhythmia. Narrow QRS complex tachyarrhythmia. Okay. Narrow QRS complex tachyarrhythmia, atrial fibrillation. Got it? Okay. So this atrial fibrillation, which is narrow QRS complex tachyarrhythmia, how do we manage? Any tachyarrhythmia, what do we see? In any tachyarrhythmia, we have to see two things. Number one, whether the patient is symptomatic or asymptomatic. Okay. Now, tachyarrhythmia is always treated, whether symptomatic or asymptomatic. But if the patient is symptomatic, we don't bother whether it is AF or PSVT or flutter or BT. Okay. Asymptomatic. If the patient is asymptomatic, right? Then we see the QRS complex. Narrow QRS complex tachyarrhythmia. Here you can see the QRS complex is less than 0.12. It's only one small box, which is 0.04. So narrow QRS complex tachyarrhythmia. Narrow QRS complex tachyarrhythmia, which is PSVT, flutter, or fibrillation. Now, if it is PSVT, we do vagal maneuver and adenosine. If it is flutter and fibrillation, we just give beta blocker and we try to control the rate of ventricles. Got it? If it is broad QRS complex tachyarrhythmia, what do? We give anti-arrhythmic drug. Okay, this is how we manage. So here, patient was deteriorating, hemodynamics was deteriorating. Patient comes under symptomatic tachyarrhythmia. So what we will do? We will do cardioversion. Yes, guys, we will do cardioversion. Is it clear, everyone? Anuj, why you have written esmolol? It is symptomatic tachyarrhythmia. If it was asymptomatic, I would have given a beta blocker. But in symptomatic, I would immediately do cardioversion. Got it? Any doubt? I hope, Taki, you will not make a mistake. I am suspecting one question will be asked. No doubt. There would be a question on fibrillation or flutter or PSVT. You're getting my point. If they are symptomatic, the answer would be same, cardioversion. If it is asymptomatic in PSVT, it is vagal or adenosine. We start with vagal, 20% change on vagal, not change, adenosine. Dose of adenosine, 6 milligram, followed by 12 milligram, followed by 18 milligram. And if it's flutter or fibrillation, we just control the ventricular rate. Broad QRS, we give antiarrhythmic. Antiarrhythmic like sotalol, amiodarone, or your procainamide. Okay? Okay. Next question. A patient with acute stroke presented to emergency with tongue fall, and OPA was to be introduced to maintain the patency of the airway. How could the right size of OPA we would determine? So guys, again, this is a very expected question. They have given so many questions on the maneuvers, head tilt, chin lift, and jaw thrust. So if they will move one step further, they will start asking about the basic airway adjuncts. So devices which we use to open the airway. So device used to open airway. Oropharyngeal airway, OPA. Oropharyngeal airway. Or nasopharyngeal airway. Nasopharyngeal airway. Now, both of them come in assorted sizes. Different sizes for every person. So first thing which we do when we put it, choose the correct size. So for OPA, measure the length from angle of mouth to angle of mandible. And most of you have given me the right answer. Cool, guys. So very nice, unexpected question. So we measure the length from angle of mouth to angle of mandible. So very quick, we'll revise. For OPA, from angle of mouth to angle of mandible. For NPA, from tip of nose to ear lobule. For Rice tube, how far a Rice tube will be inserted? The length of Rice tube which you will put. How do you measure before inserting the Rice tube? From, yes, ear lobule to, tell me, you write it. From ear lobule to tip of the nose to Xiphi sternum, 5 centimeter below the Xiphi sternum, right? So from ear lobule to tip of the nose to 5 centimeter below the Xiphi sternum. We palpate the Xiphi sternum 5 centimeter. If it is not given in the option 5 centimeter or midway between Xiphi sternum and umbilicus, go for till Xiphi sternum. Got my point? But yeah, from ear lobule, yeah, if it is not given 5 centimeter below Xiphi sternum, go for Xiphi sternum, right? If it is given 5 centimeter below Xiphi sternum, we go 5 centimeter below Xiphi sternum. I'm telling you, you can go till Xiphi sternum as an answer. But if it is not given, 5 centimeter below Xiphi sternum, right? So from ear lobule to tip of the nose to 5 centimeter below Xiphi sternum. All right? Okay, next question. Okay. A patient with history of COPD, hypertension and anemia is brought to emergency. His vital signs are blood pressure 182/98, heart rate 90, respiratory rate 32, oxygen saturation 78% on room air, temperature 98.6. On physical examination is confused, appears anxious, uses accessory respiratory muscle, which is the best method of giving oxygen to the patient. Who will give me the answer? So what are the things? COPD. Patient is having COPD and now patient comes in hypoxemia. Right? So you definitely have to give oxygen. Now guys, when the patient is having is in hypoxemia and he is having symptoms of hypoxemia and respiratory muscles are right. Respiratory muscles are right. So what I'm trying to say is if clinical features of confusion, etc. is coming because of hypoxia, so what you should do, right? Don't go for like simple oxygen delivering device. Try to assist the respiration of the patient. In COPD patient, the first device we always use is BiPAP, bi-level positive airway pressure. Very good, Raj. This is the answer, right? This is the answer. Bi-level positive airway pressure. Bi-level positive airway pressure. Okay. So this should be the answer for the method of oxygenation we will give to the patient. Simple. If you have a patient with COPD and there is just a mild hypoxemia, that is the saturation between 88 to 92%. So we will just put a nasal cannula, right? Maximum. But if it is moderate to severe hypoxemia, we always put a COPD patient on BiPAP, bi-level positive airway pressure. And we always start with inspiratory airway pressure at your 12 mm of Hg and EPAP, that is expiratory positive airway pressure, right, at, let's say, 8 mm of Hg. Okay. So we start with, let's say, this much BiPAP support, 12 and 8, 12 and 8, right? If patient tidal CO2 is not decreasing, right? If patient CO2 is not decreasing, right, what we will do, we will increase this gap, the IPAP minus EPAP. This IPAP minus EPAP is something which is called pressure support of BiPAP. And this would augment augment tidal volume. So what will happen? If we will augment the tidal volume, PaCO2 will decrease. So CO2 will decrease. If patient oxygenation is poor, then we increase EPAP only. Then we increase EPAP because EPAP is something what is PEEP for ventilator. And what PEEP did? It improved oxygenation. So EPAP here will improve oxygenation. And the gap between IPAP and EPAP would be the pressure support, which will augment ventilation. So I have told you one step further, the setting of BiPAP machine. Now, this patient was having severe hypoxemia. Oxygen saturation was very low. So I have set the EPAP at a higher level. Okay. The patient had oxygenation normal, near normal, but CO2 was very high. Then I would have kept the gap more, 12 and 6. You are getting my point? This difference, IPAP minus EPAP, difference as it increases, the pressure support increases and it augments the tidal volume. And for oxygenation, to improve it, we only have to increase the EPAP. In EPAP is something what is PEEP on mechanical ventilation, right? EPAP is something which is PEEP on mechanical ventilation. Got it? Okay, I hope you have understood this. This is again something if they go one step further. Okay, next question. A 57 years old female is posted for laparoscopic cholecystectomy. She had a medical background of type 2 diabetes. Her glycosylated HB is 6%. She also has a history of heart problem and is dyspneic while doing normal household work. She belongs to ASA grade. Yes, answer. Everyone, ASA grading, I'm expecting to be asked in exam. So I will revise ASA grade with you. ASA grade, which tell us about the risk associated with surgery. So we have 6 ASA grade 1, 2, 3, 4, 5, and 6. We have ASA grade 1, 2, 3, 4, 5, and 6. 6 ASA grades. Now, ASA grade 1, no comorbidity. No comorbidity. Patient doesn't have any comorbidity. ASA grade 2, mild systemic disease. Mild systemic disease. Patient is having comorbidity, but is symptomatic. 3 is moderate to severe systemic disease. Moderate to severe systemic disease. In this, patient is symptomatic on strenuous work. 4 is life-threatening systemic disease or systemic disease which is not compatible with life. So this patient is dyspneic while doing normal household work. Patient is dyspneic while doing normal household work. It will again come in ASA grade 3. Patient, if the same question I twist, patient is dyspneic at rest. Patient is dyspneic at rest. Then he belongs to ASA grade 4. Patient is dyspneic normal household work. 3. Patient is dyspneic on strenuous activity. Then also the answer is 3. Patient is not symptomatic, just have the heart disease, but is well controlled, not symptomatic. 2. And patient is having no heart disease, no comorbidity. 1. Any doubt? Yes. Bhuvana has written 4. Well, Bhuvana, I have particularly put this question just to create a little confusion and then to clarify the confusion. Yes, you can get confused that is it 4? Actually, if the patient is at a rest having symptom, I'm talking, I cannot talk, even while speaking one line, I am dyspneic, then I am 4. This is not compatible with life. But little activity is precipitating the symptom. Then it comes under moderate to severe disease, which is ASA grade 3, right? 1 ASA grade 3. So you have understood, Bhuvana? Okay. Yes. Yeah, Bhuvana. So you have understood the answer? Okay. So clear, everyone? This will come. This will come in exam somehow. My heart says, right? Next question. The oxygen flush valve, all are true except A flow between 25 to 50 liters per minute can be delivered. Barotrauma has been reported on its use. Then it can be activated regardless of the master switch on and off. It deliver oxygen at a pressure of 55 to 60 psi pressure. So oxygen flush valve, which is present in anesthesia machine. So guys, this is your anesthesia machine. This is the outlet. Just beside the outlet, there is a black button surrounded by white halo. Right? There is a black button surrounded by white halo. So what do we do when we press it? When we press it, it releases from the outlet. When we press it, it releases minimum 35 liters of oxygen to 75 liters of oxygen. Correct? So the first option, flow between 25 to 50 liters, is incorrect. Right? Now, this is something which comes under intermediate pressure system. So it will have the pressure of intermediate pressure system. It bypasses the low pressure system. So it has a pressure of, it delivers the gases at pressure of 55 to 60 psi. Let's say 40 to 60 psi if I keep a higher range, but never 10, 12 psi, which a low pressure system gives the oxygen at a pressure of. So it comes under intermediate pressure system. Okay. Then it is operational even when there is no power supply to the machine. And if we press it, what happens when you press the washroom flush? If it if it does not come back to its original position, what happens? The oxygen the water goes on coming. Same thing can happen with this flush also. This is also flush. If it is stuck, it will go on giving oxygen at a very high flow and at a high pressure. Barotrauma can happen. So barotrauma has been reported. So this is a wrong option. So what is not true? First one is not true. Okay. So this is the answer. Okay. Next question. So just summarizing once the oxygen flush valve. Oxygen flush valve. Just summarize it. Number one, it comes under intermediate pressure system. Number two, it gives the oxygen between 35 to 75 liters per minute. Number three, it is operational even in absence of electrical supply. And it gives oxygen at a pressure of 55 to 60 psi pressure. Okay. Next question. Which of the following is most common local anesthetic used for IVRA? Again, a very expected question. IVRA, the most common local anesthetic used. IVRA, intravenous regional anesthesia, or Bayer's block. Bayer's block. So IVRA or Bayer's block, intravenous regional anesthesia or Bayer's block. So what we do in this, we put a tourniquet in the hand or lower limb, inflate the tourniquet, double the blood pressure of the patient, put a cannula in this hand and give a local anesthetic through this cannula. It remains in this limb, does not go in the systemic circulation. So this is IVRA, regional anesthesia, but through IV route. Which is the best drug? The most safest drug we will use in it because there's a risk. Since the drug is given IV, it can go in the systemic circulation. So lignocaine is the safest LA. It is the LA of choice. So everyone has given me the right answer. Again, an expected question. If they ask something else from this is being asked from years. They can ask which is contraindicated. So agent of choice is lignocaine for IVRA. IVRA, agent of choice, ligno. Or if I don't want to use ligno, I can use prilocaine. Agent, local anesthetic contraindicated. Bupivacaine. Okay. Okay. So bupivacaine is not used. This is never used. Ropivacaine, the congener of bupivacaine is never used. Okay. So keep it in hand. In your mind. Okay. So this is all about the 22nd question. Coming on 23rd question. Soon after administration of epidural block with 1.5% lignocaine with epinephrine, the patient went into brady, hypo, and apnea. What is the most likely diagnosis? Okay. Krish, has given me the answer cardiotoxicity. Okay. Cardiotoxicity. That is. Okay, guys. Only two things can be the answer. Little change in the symptom. This is your spinal cord via arachnoid dura. So I wanted to give drug outside dura mater for epidural, right? So in epidural, we give a large volume of drug, 15-20 ml. By mistake, my needle went into subdural space or even bad subarachnoid space, and my drug went into subarachnoid space. So if a large volume of drug will go into subarachnoid space, immediately the 31 pair of spinal nerve root will get blocked. And the symptoms which will happen of total spinal anesthesia. Total spinal anesthesia. So total spinal anesthesia, what will be the symptom? Hypotension, bradycardia, and respiratory depression. Hypo, brady, respiratory depression. This is a typical symptom of total spinal anesthesia. So this is what my patient has got. So this answer is accidental subarachnoid injection of the drug. If after giving the drug, patient had the symptoms like perioral numbness, tinnitus, seizure, and then maybe hypotension also, then it would be the local anesthetic systemic toxicity like cardiotoxicity, etc. Right? So local anesthetic systemic toxicity. So just have to see what symptoms are coming. If it is neuro symptoms, numbness, tinnitus, seizure, then it is local anesthetic systemic toxicity. And if it is hypobrady, then answer has to be total spinal. That is, drug has gone into subarachnoid space. I hope you have know the answer. Answer is accidental subarachnoid injection. 24th question. Because of which there is resistance to breathing of the tube shown below. So when we breathe through ET tube, what causes resistance to breathing? Again, this is a very favorite question of exam. So what causes resistance to breathing? Very good. Most of you are giving me the right answer. Resistance is directly proportional to length, inversely proportional to the radius power of 4, right? So resistance depends upon length, radius, even on curvature, but it depends maximally on the radius because to the power of 4. So little decrease in the radius increases the resistance 4 times. So little change in the diameter of the breathing lumen, which was initially trachea. This is the trachea. Trachea has the diameter tube. Normally, in adult male, it has the diameter, let's say 7.5 mm. In female, in female 7.5, in adult male, it is 8.5 mm. So 20 mm, it became 8.5, 7.5 mm. So radius diameter decreased, the resistance to the breathing increased. So it is because of this diameter. Again, an expected question. Twice in your exam, it has been asked. Again, it can be asked. So go for answer as your diameter. Even circumference is the outer diameter. Don't bother about that. You will have to answer diameter or radius. Got it? Okay. Okay, next, last question. A young patient posted for congenital cataract surgery under general anesthesia. To secure the airway, supraglottic airway device was used. All of the benefit of supraglottic airway device over the tube except. So supraglottic airway device, all our benefit. Supraglottic airway device is another airway device for positive pressure ventilation. We can use it. But it has all the benefits over tube, but with one demerit. That it is not as good as tube in preventing aspiration. Right? So guys, just the last point of discussion for the today's session. Supraglottic airway device like laryngeal mask airway and endotracheal tube. Right? Now, LMA is easy to insert compared to tube, fast to insert compared to the tube, less invasive, so better compared to the tube. But if this is trachea, I have put the tube, inflated the cuff, it creates a very good seal, best seal, aspiration prevented. But this remains above the glottic opening. It also creates a seal, but this seal does not prevent aspiration as good as it prevented by ET tube. So answer has to be, it prevents aspiration. This is a wrong option. Advantage of supraglottic over ET tube. This is a disadvantage of supraglottic over ET tube. It cannot prevent aspiration. So it cannot prevent ET tube. Okay. It is fast. It causes less hemodynamic alteration. It is less invasive. But it cannot prevent aspiration as good as ET tube. That's the major issue. Therefore, patient with a high risk of aspiration, we always intubate. We don't put supraglottic airway device. So answer has to be your C. Okay. Remember, first generation supraglottic airway device does not prevent aspiration. ProSeal, LMA, iGel, but I'm still saying comparable. Best is what? Endotracheal tube in preventing aspiration. So still the best tube to prevent aspiration is endotracheal tube. All right. So keep this in mind. Okay. So this is our last question. Any query? You are most welcome. Oxygen cylinder, just remember the color coding. So many times we have discussed. Zebra crossing is the color coding for oxygen cylinder. Black body, white shoulder. Black body, white shoulder. Yes, keep it in mind. But from last few years, I'm not seeing a question on it. Okay. Ventilator, one thing I'm expecting a question. Oxygen therapy, I'm expecting a question. ASA grading, I'm expecting a question. Right? Okay. Cylinder, just remember the color coding. Just remember the color coding. And so for cylinder, just remember the color codings. For cylinder, color coding and pin index. Pin index, two things. Yes, Jaya, just pin index. And for pin index, so many times I have told you to remember 152535, 162636. Nitrous oxide 3 atom, 35. Oxygen 2 atom, 25. Air mixture 15. 6 is like C, so all the gases from C is in the 6 system. 1626 carbon dioxide, 36 cyclopropane. Cyclopropane. So these are the way of remembering the color. So this is all I wanted to discuss. I hope you had a good session. I had an amazing session with you. Okay. Induction agent. What induction agent? Inhalational induction agent of choice is SIBO. Induction agent of choice for inhalational, anywhere the answer has to be SIBO. No other answer, induction agent. Okay. And for IV, according to the presentation of the patient, shock, Ketamin, cardiovascular instability, etomidate, right? Bronchial asthma, Ketamin, rest anything, propofol. Rest anything, propofol, right? So I had an amazing session. I hope you also had it. Thank you so much for your patient listening. Best of luck for your exam. Do very well. Go fearless. Perform your best. We will see the result. We will see the result. Don't bother about the result. Bother only about giving your best shot. So my best wishes. I hope you will do too good in the exam. Bye.